Hi, my name is Diana Barrett, and I'm the founder of SurvivorCore. And this webinar series is one of my favorite parts about SurvivorCore because we understand that you can't always get to the experts. So SurvivorCore is here to bring the experts to you. And today's topic is something that I think any of us who had COVID from a mild case to a severe case can relate to. And that is, how do you recondition? How do you get back into shape? How do you do it properly? How do you do it safely? And so we are extraordinarily lucky today to have three specialists who in cardiovascular pulmonary physical therapy from the American Physical Therapy Association, which created the P.A.C.E.R program, which is what we are going to be discussing today. So without further ado, we have Angela, Talia, and Ellen here, and I'm gonna let them just do a quick introduction so that they can give you a bit of background on their areas of specialty, and then we'll start with all of the questions you guys have been sending in. Thank you so much for being so active and so participatory, and we love how many questions we get for each of these webinars. Keep on sending them in. Okay. Angela, do you want to go first?
Absolutely. Hi, everyone. My name is Angela Campbell. I'm a professor of physical therapy from Springfield College in Massachusetts, and I am the current president of the APTA Academy of Cardiovascular and Pulmonary Physical Therapy, which is a component of the APTA.
Okay, Talia.
I'm Talia Pollok. I'm a clinician, a full-time clinician between two hospital systems here in Virginia, UVA Health and Centra Health. I've worked in critical care for almost 13 years now, typically with patients who have lots of heart and lung issues. And I'm currently the education chair for the academy that Angela just mentioned.
Okay, and last but not least, Ellen.
Hi, I'm Ellen Hillegass, and I'm the the president and CEO of PT Cardiopulmonary Educators, a web-based education company for continuing ed and academic education, as well as an adjunct professor at Mercer University and a board-certified cardiopulmonary clinical specialist. And I'm so glad to be here. Thanks for inviting us.
Thank you all for being here with us. This is great, and I'm always so humbled when I hear all of our guests' incredible degrees and accomplishments. It's always phenomenally humbling, but I'm so impressed as well. Angela, let's start out. Can you just tell us? Let's just start out with what is the P.A.C.E.R program? Can you just explain it from the beginning?
Yes, yeah. The P.A.C.E.R project started in late March, which was early in this pandemic. P.A.C.E.R stands for Post-Acute COVID Exercise and Rehabilitation. And it really started as seeing through social media a lot of information, but a lot of disinformation about COVID, and starting to think about how, the three of us, we work with people with heart and lung problems and breathing problems all the time. But a lot of our other physical therapy colleagues here in the US and across the world do not. And so how do we get them back tuned up and ready to go and get a core of physical therapists ready to meet this pandemic head on? And it's just really evolved from there. So it's a whole set of free educational courses. This has been like my fantasy football league. So when I recruited all the people into it, it was literally the dream team. So there are people who are nationally and internationally known experts that are leading these free courses to clinicians everywhere.
That's incredible. One of the things that SurvivorCore is doing is we are advocating for long-term COVID care centers throughout the country. And on our website, we have probably the most comprehensive listing of the existing long-term COVID care centers that exist currently. And it's an incredible resource, so please check it out on survivorcore.com. One of the things that we find is we're looking through and constantly updating our files and our information, that a lot of the rehabilitation programs are really geared towards people who had been in the ICU, dealing with post-ICU issues, and were primarily just pulmonary rehabilitation. So is P.A.C.E.R something that also applies for those of us who had the Tylenol and Gatorade varieties of COVID like I did, where I never came close to having to be hospitalized, but it's 10 months later and I have just started to exercise?
Yeah, they absolutely have. So as the first couple segments were developed, we really added on, and so we added. I was talking with someone who's a neurologic specialist, for example, and really early into this pandemic, she was like, I don't really know how, the neurologic system fits into this. And then, I mean, literally then you're starting to see some of these COVID related strokes and other things. So we got that information. We have them tailored to the home health setting. We have them tailored to the return to sport and the outpatient setting. So we really have gone on to develop these more and more as we've gone. And I think, your point about the Gatorade and the Tylenol is that what we're seeing with a lot of this long COVID is that this P.A.C.E.R syndrome that has a lot of neurologic, muscular, and other things, it's almost, and you talked about a picture in our pregame warm up here of this long COVID damage. So these people that maybe never went to the hospital actually look like they have post-intensive care syndrome in a lot of ways. So it's been very helpful, I think.
It is frightening. To fill you all in so you're not left out of the joke, although it is far from a joke. If you all are on Twitter, follow me. I am at Diana Barrett. I just posted images that were on a PBS NewsHour program that featured SurvivorCore and was focused on long-term COVID. And Dr. Lee presented before and after photos of both lungs and hearts from mild, the Tylenol and Gatorade kinds of COVID that so many of us had and are still struggling with. They are very frightening. I urge you to look at them and share them. So my next question, Angela, you're not getting away so quickly. How many physical therapists have completed the P.A.C.E.R program, and how do you find out who in your area is familiar with post-COVID specific issues or P.A.C.E.R techniques and recommendations?
Yeah, that's a great question. So hindsight is always 2020, and I know 2020 is kind of a bad word to use in itself. But one of our things was that we wanted to get this information out as fast as possible and as widely as possible. So we've made all of this information free to anyone across the world. So it's been on our YouTube page, our Facebook page. There's links through Twitter, and we tracked how many uses that they have, but we don't track where people come from. So we have feedback that occupational therapists have taken these courses, respiratory therapists have taken these courses, people from other countries, from other continents have taken these courses, but we don't really have that level of data. I mean, we do know that over 165,000 people have used them on Facebook, that over 100,000 people have used them on YouTube. We know through the American, physical therapists can get continuing education credit through the American Physical Therapy Association website. We have those numbers as well. It's a roughly 5,000 have been starting to use these courses. So we have that kind of data. But
I'm not sure if we're already linked to you guys on our website, but assuming that we are, and if we're not, we should be, would someone be able to go to SurvivorCore and link to that registry so that they could find a physical therapist who's trained in this technique near them?
So we don't have a listing of who's trained in those techniques. And again, I think we've talked about maybe one of the follow-up projects might be a P.A.C.E.R certification sort of a thing. But what they can do, and I think that's, I know we have even a slide on that if we want to queue it up, but it's how, I know you've talked about these in these webinars before, how there's so many people in so many places that are having these symptoms and they're not getting the attention they deserve. And it's about finding the right clinician to treat them. And it might be a physical therapist, it might be a team of people to do this, but they really need to find it. And patients, they need to advocate for themselves. And one of the things they can do is they can bring articles. They can ask, have you taken these courses, or have you taken in COVID-19 specific courses? and ask that information. And if they haven't, they might need to see someone else. So maybe that someone who they saw for their knee rehab isn't somebody who they should be seeing for their COVID-19 rehab. A lot of those outpatient orthopedic therapists have, gone on to adapt themselves and train, but not all of them have.
So, you started, the next question I have, you actually started to answer, and then we'll move on to Talia. So you're on deck. But, the P.A.C.E.R program, as you said, was started in April. And, we obviously know a lot more now about the vascular nature, the inflammatory nature of the disease, the extensive organ damage. One of the fascinating things that we found in our research is because we allowed our membership to write in many of their own answers rather than just clicking off from a survey, we were able to really tease out the difference between fatigue and inability to exercise. And inability to exercise has been one of the most top ranked long-term symptoms that really interferes with people's lives. Like it is, people find it depressing. I certainly did. I was never fatigued, but I could not exercise until very recently. So, this is affecting so many of us. How has the program been updated, as we're continuing to learn more and more about the disease?
Yeah. So some of the courses have rolled out as there's been new information. And one of the courses that we have that's coming out is actually on post-viral syndrome specifically. So Dr. Todd Davenport is working on that. So if you've heard of, chronic fatigue syndrome, the myalgic encephalomyelitis, that whole picture, the CFS syndrome that a lot of you I know have been talked about. So there's a course coming out on that soon. So that's an example of knowing that we have this continuing need to adapt. I think a lot of it is the translation of knowledge to how does this maybe P.A.C.E.R syndrome that is in some ways also common, because some of these features of inability to exercise and gain muscle mass and the atrophy that persists longer than it should is happening in people that weren't even hospitalized, and is getting that information to the clinician. I think that's been one of the really big things. But as physical therapists, we should be seeing everyone as an N of one. And from the research side, what that means is that we're needing to tailor things individually. And so while some of the underlying physiology and the knowledge of the physiology has changing, we still treat people by what impairments they have, what things are they not able to participate in, and we're able to modify things that way. But you're right. As far as some of this data about, certain people, and I know Talia is going to be talking about that in a little bit, but certain people, you need to really dose exercise carefully. We need to think about exercise as medicine. And if we think about exercise as medicine, it's about the right dose. And a lot of us shouldn't just be taken over the counter, meaning that we're just determining our own dose, but that we might need the help of a professional.
Right. So obviously, we're used to thinking if you get sick, you want to get back in good shape. But what do? You start working out again. And one of the striking things I've seen in our SurvivorCore membership is the number of athletes, the number of people who were in really, really good shape before they got COVID and are now really suffering and, can hardly walk up a flight of stairs when they were running marathons a year ago. So Talia, why are COVID patients and those with long-term COVID experiencing fatigue and exhaustion, and in some cases an aversion or inability to exercise, even if they were in top physical condition before contracting COVID?
I think that's a really good question. And I think the jury is still out. There are a lot of different hypotheses about that. I'm going to say what we say to students, and students don't like it, but it depends. It really does depend. And I think you have to really put it in context of kind of what daily activities and what return to sport looks like for an individual person. And I think what I would ask any patient that kind of came to me and said, well, I can't do what I was doing before. And my question would be, well, why not? What kind of symptomatology do you have? Is it pain? Is it shortness of breath? Is it fatigue during the activity? Is it a post-fatigue? So I would really try to hone in on, kind of like Angela said, what specifically which specific symptoms are you presenting with, and then let's work from there. I think the myalgic.
I would say that a lot of our members, a very consistent report is even the smallest exertion will put them in bed for hours or days.
So that sounds a lot like what we know to be a post-exertional malaise, which is a component of this myalgic encephalomyelitis/chronic fatigue syndrome. So for the duration of this, because that's a lot of words, I'm going to just call it MECFS. And that's what we know it to be in the literature as well. So that is a hallmark symptom. And it's really difficult to quantify. Todd Davenport and his group at the workwellfoundation.org, they're out of California. They're doing a lot of cardiopulmonary exercise testing. So how when you see folks with the big mask on and they're on a bike, and that's a cardiopulmonary exercise test, they are actually having folks come in with MECFS to do these tests. And they kind of say ahead of time, you're really going to this is going to kick up your symptoms, but it is going to allow us to find a heart rate where we can figure out where you are having most of your symptoms so that we can give you a range to kind of work within. So
have a customized threshold, you wear your heart rate monitor, and if, I'm a con person myself, but that way, so I would be able to track and make sure that I stayed within a certain heart rate zone. Is that?
That's right. And it's, you can use heart rate. If you don't have access to a heart rate monitor, there are other scales that you can use, rate of perceived exertion, which we'll talk about. But really,
monitors are cheap on Amazon, guys.
They are, but they are cheap. They are cheap. If that's not the case, you can certainly palpate your own heart rate. Think about your symptoms. Do a lot of journaling. I think that's the best way to really explain to your provider, whether it's a PT, a physician, or whomever you feel comfortable going to, sort of how your symptoms are, and more importantly, when your symptoms are. And we don't really know why some folks continue to have this post-viral syndrome. There's some good work coming out now out of Brigham and Women's Hospital at Harvard, where they're sort of talking about this sort of innate brain response where your body kind of goes into a power down mode when you have a viral or otherwise infectious illness. And these illnesses can present in many different ways, but the point is that your body goes into the shutdown mode so that you can effectively fight off that virus or fight off whatever invader has come in your body. So when the invader has exited, you can go into your power up mode, essentially. For whatever reason that is yet unclear, this power up response doesn't really happen. You're still, even in the absence of the virus, you're still in that power down mode. And what that leads to is this potentially, sort of constellation of symptoms, this post-viral syndrome, with chronic fatigue, inflammation, vasculitis, everything you see here. And it sort of presents itself in, headaches, dizziness, muscle pain, inability to change your body position without feeling dizzy, without feeling dizzy. You can't catch your breath. You're constantly coughing. Probably a lot of things that your members have reported and sadly experienced.
Absolutely. And, it was interesting. I was talking to Mike Joyner yesterday from the Mayo Clinic, who's, been very involved in plasma, but he's a physiologist, by trade. And we were talking about exercise and getting back into shape after COVID. And he was talking about the sort of catch-22 about the benefits of exercise for your health. But then, the inability to get back into that routine and what a catch-22 that presents. So any way that you can figure out how to slowly get back into that. One question that we haven't touched on, and Ellen, maybe you're the right person. Well, Talia, I'll finish asking this before we move on. What is the difference between physical therapy and a recovery regimen that's targeted at reconditioning versus one that's focused on recovery from organ, pulmonary, or vascular damage?
Well, that's also a good question. And again, the answer is it depends. You know, if you're the Tylenol and Gatorade type of COVID, but you're still having some debilitating symptoms that kind of make me think that you kind of look like someone who may have been hospitalized and in the ICU, I'm going to sort of come at you and treat you in a very similar fashion. So, for example, you know, when I see patients in the intensive care unit, just actually, you know, within this past week, you walk in and, you know, you're looking at the big picture. You're looking at the big picture. I'm looking at the monitor. I'm looking at mostly looking at the patients. I'm looking at all the things in the room. And I'm trying to consider how many organ systems are involved here and what's the risk to benefit of me doing very basic mobility. If you've been in bed for 1 day to 10 days, whatever it's been, getting up for the first time might be a little bit dramatic. If you have multiple organ systems involved, it's going to feel very different. So really in the hospital, we're working on very basic, getting up to the side of the bed. Can you sit there on your own and maintain? Are you dizzy? Can you breathe? How does your heart look? How do you feel? What's in your eyes? Can I see that you're okay, you know, in your eyes, despite all of the things around you? And then once we kind of transition out of the hospital, where we've really tried to focus on, again, what we call functional activities, standing, walking, standing at the sink to brush your teeth, being able to breathe while you walk, getting in and out of a restroom, basic things that we would all typically take for granted. It's really difficult after a prolonged illness. So that's sort of what we're going to focus on in the hospital. After that,
the issue is that many of our non-hospitalized patients are experiencing that exact thing, yet they're not getting the help from hospital-based physical therapists. So they're at home and really, you know, at a loss for how to, like, what are your suggestions for, you know, with your home and in this situation, you know, what does one do? Where do you start?
So typically what we would recommend is getting in touch if you have a primary care physician or a family physician. If you're really unable to safely navigate your home or to get out of your house to go to a physician appointment or otherwise an appointment, you can get a referral for home health services. And a home health nurse, or generally a nurse or a physical therapist, will come out and do an assessment of how you navigate and move within your home. Can you go up the stairs to your bedroom if you have stairs? Can you access, you know, your bathroom safely? Do you need a seat in the shower because you're so tired just standing, you know, for 5 minutes to wash your hair if that's the way that you function? That's where generally we would start. If you're able to still get out of the house, but your quality of life is not such that you can really engage, then we would definitely consider a referral to an outpatient physical therapist. And the resources in the slide that Angela had up earlier, you can find a PT in your area, and you can also find a cardiovascular and pulmonary specialist in your area through our registry, our website.
Are there any self-guided tips and, you know, programs as well?
Yeah, not everybody, you know, physical therapy in a lot of places, or pulmonary or cardiac rehab, can be a difficult, it can be a really difficult service to access. And it can be expensive too, you know, we know that. So I think what I would start out with, honestly, I was thinking about this last night or this morning at 3 o'clock when I was awake, anticipating this. I would, you know, find a measurable distance within your home. Okay, stand up, walk that distance, and then sit down. Time yourself. How long does it take for me to get from point A to point B? How hard am I working to breathe on a scale of 0 to 10? And do I have any other symptoms? Am I dizzy? Am I short of breath? Do I have a headache? Is my throat sore? And I would kind of start there to get your baseline. Take your heart rate if you have a heart rate monitor before exercise, if you can get it during exercise, and then afterwards. Write it down. That's your baseline. I think it's a lot about being very self-aware of what your body is experiencing during the activity. And I think more importantly for our folks, for post-viral, is the afterwards. How do you feel 5 minutes after your activity?
What is your rate?
That's correct. Or, get up and take a shower. How do you feel during the shower? How long was your shower? Was it 10 minutes? Was it 30 minutes? Was the water hot? Was it a little bit lukewarm?
So a fitness tracker, like, one of the newer Fitbits, or I don't have an iPhone, but I hear Apple Watches have this functionality, but investment in some sort of fitness tracker that can track these, if one can, seems like a good investment, no?
I think definitely if you're a person that's into kind of that technological and kind of feedback, you can certainly have something that will count your steps for you. So if you don't know what the distance is, you can certainly count your steps in a particular period of time, capture your heart rate. I know I have used the Apple Watch, and that is pretty consistent with my chest strap monitor that I use when I exercise. So that is good. Or, old fashioned simple palpation, your carotid artery and certainly at your wrist. So yeah, I think those are great if you want to do some objective tracking. If you're a pen and paper person, I tend to kick it old school and I like pen and paper. I might just kind of journal and write down so that I have my objective data, my heart rate of perceived exertion, just like you're seeing on this chart. And then I'm going to write down some subjective things, did I sleep well last night? What have I eaten today? Have I had enough to drink? That it's a big picture. You can't just isolate a heart rate or an O2 sat or something like that. This is a big picture set of data that we want to know. That's, as a PT, that's the kind of thing that would be like gold to me if you presented that to me in our first session, if I could see all of those things, for like a couple of days or something.
That's great advice. Ellen, what sort of dangers or warning signs should you be aware of if you're trying to recover without a guide therapist? And we sort of touched on this a little bit earlier, but if you can go into a little bit further depth on how do you find, the challenge, not just of finding somebody with the right credentials, but the financial piece of it. And of course, it's January, all of our, everything has reset in terms of our benefits and our deductibles. And so, the hardest time of the year to go get doctor's appointments in terms of the financial constraints.
Well, so you have some great points that I would love to address because I do realize a lot of people who've gotten COVID have high HSAs, they have high copays, and they have higher deductibles, and that's all hitting now. And so it's very important to think about these things in January. So my suggestions first are to do as much as you can on your own. And when you feel you're not progressing, that's when you should seek the professional and then look into paying for sessions as far as that goes. And if you're limited by payment, then talk to your therapist about what can I do on my own because I can't afford to keep coming in on 3 times a week or whatever, and give me guidance so I can do stuff at home and then come back in for a checkup with you. What they should be looking for is really abnormal signs during their activity. And I'm going to tell you, you have to reset your expectations. I exercise regularly, and if I don't exercise, I simply climb the walls. So if I had COVID and I was out for a couple of weeks and I was trying to get back into exercise, my expectations would never be met. And that's what's happening. We're not meeting our expectations.
Oh, you can take a look at my Peloton scores 10 months later for a perfect illustration of that. I'm lucky if I can get half the numbers. I'm a total data hound, and I keep every metric, everything. And my scores are abysmal, but I thank God can finally do it. So I'm just happy I can get through it.
But there are a lot of people like you have to start very slow.
Yeah.
And so we had the perceived exertion chart up earlier, and that's a great one to look at. Try and work to about a 5 with whatever activity. Now the 5 might be from walking from here to 100 feet in the very beginning. And then just do multiple bouts of that with frequent rests. We work, both Angela, Talia, and myself, we work with patients with heart failure who have very poor pumps and very poor exercise tolerance. And we can get them to walking 30, 45 minutes continuously when they started with these very short bouts. So it's very critical to reset your expectations and to work at bouts of exercise, not endurance at first. And so build up your bouts at home until you feel like you can't build up anymore and you're stopping because of abnormal signs or symptoms, abnormal heart rate rise, chest pains with activity, shortness of breath of a 10 or a 9, if with simple activities. Those are some abnormal signs. And if you have a pulse oximeter, seeing that your pulse ox drops with activity. Those would be things to see someone about. There are some concerns early post-COVID, both in the hospitalized patients and the non-hospitalized patients. We're seeing a lot of vasculitis. This inflammatory response causes a vasculitis.
Can you explain exactly what vasculitis is?
Sure. It's an inflammation of the vessels, mostly arterial, but we're seeing it in venous. And what we're predominantly seeing is that people have a greater ability to clot. And
is that the same as when we're talking about damage to the endothelial lining of the vasculature, or is it different?
Yes, that's it.
Okay.
And this inflammatory COVID virus causes this damage to the endothelium, which can allow clots to build up, particularly in the legs. And we're seeing a lot more clots going to the lungs.
Right.
So I mean,
that's what we're seeing when we see COVID toes. Those are clots that are cutting off circulation to the toes, right? I mean,
yes.
I was diagnosed with COVID onset glaucoma, and they found microclots in my eyes and fraying of the capillaries. My son had it in his jaw and lost a tooth. I have friends who have suffered really significant lung decapacity, the destruction of the vasculature, 40% reduced capacity from all this. So, it really does seem that any organ that relies on blood flow can be, really damaged by these blood clots. Is that correct?
Yes. And we see it in the hospitalized. They even clot off their tubes, like the kidney, the dialysis. They're clotting off from those. They're clotting off from many of their IVs. So we're seeing it in hospital. We're seeing it out of hospital. Interesting enough, we're seeing the risk of the microvascular thrombotic issues are decreasing over time when you're home. So 4 to 6 weeks after your 2-week stint of COVID, we're seeing a much greater decrease in the thromboses. So someone like you're really not at risk now, and you're also very active. So we see these clots in the inactive individuals, and we're also seeing it in the early parts of COVID. But interesting enough, we're not seeing it long-term. So that seems to be changing a little bit.
Although we are hearing all of these stories of young athletes who had COVID ended up with myocarditis or something and, dropped dead on the football field 4 weeks later or after an asymptomatic case. And, the current guidance, the last that I heard from the CDC was that every child and adolescent who returns to sports after COVID needs a cardiac clearance beforehand. As far as I'm concerned, gym class counts as sports. So presumably, does that mean every child and adolescent in America? And how does that apply to adults in terms of, I actually went and got a full cardiac clearance before I tried to exercise, just because I was so nervous about all of those reports. But I'm very lucky in that I have really good health insurance. If I didn't and had to be paying out of pocket for such a thing and it wasn't necessary, that would be a different thing. How necessary is it, and who should be getting those cardiac screenings, and what does a good cardiac screening entail?
So Diana, I'm going to refer you back to Dr. Fauci because I think that I can't answer who should be seeing these physicians for cardiac incidents, because I'm not sure that every child who goes to gym class requires a cardiac clearance.
Right. I mean, it's right. It seems excessive, but at the same time, I don't know where the line is.
I don't know where that line is either.
Doesn't.
But my recommendation would be is if they did have some clotting issues that they noticed, or they had chest pains, then I would definitely have these checked out. In the hospital, we are taking a lot of lab work, and we're seeing people with elevated D dimers, elevated ferritins, elevated IL-6s. These are people that are higher risk for the clotting, and they're often put on anticoagulants or antiplatelets. And just to throw in, if you don't have a bleeding risk, another type of antiplatelet drug that's over the counter is aspirin. So,
yes.
So there are possibilities for treatment
all the time. I don't know why it's not part of any sort of standard of care, but every doctor I speak to off the record has themselves on aspirin, either prophylactically if they haven't had COVID yet, and on it the second they do get it. So,
and there's fish oil, and then exercise is also has a fibrinolytic effect. So it breaks up clots.
What does that mean?
Exercise breaks up clots.
What was the word?
Fibrinolytic effect.
Oh, that's interesting. I did not
So
really.
Exercise does have a fibrinolytic effect. So if you think about, you're at higher risk for COVID when you have the worst of the COVID and you're healing. We're seeing the decrease going down 4 to 6 weeks after the 2 week of COVID. So we're seeing if people are getting more active, it may be that exercise that's helping with the clots, decreasing the clots.
Wow.
Because the incidence of the clotting, we're not seeing long-term, we are seeing it much more in the shorter term. So those returning to basketball 4 weeks after it, they're still in that window. So
right.
I would be concerned about some people going to some of these athletic kind of activities right away. And so a clearance would make sense for some of these people.
Okay. No,
and the changes in the blood work seems to be more related also to the severity of the COVID. So the more moderate to severe, we're seeing a lot more of the clotting issues. But we still have some clotting issues with the mild. So I'm not saying to ignore that. The concern that we have with clotting to the lungs and developing a PE is you would have very different symptoms. You'd feel a very high heart rate, very tachycardic, possibly dizzy, and you might feel chest pain or chest pain with a deep breath. So those are things to worry about early on in COVID, because we do see this hypercoagulability in these post-COVID patients.
So if you could just go over those sort of warning triggers again, just so that everyone can pay attention of, at what point do you, just put everything down, call the doctor and,
Well, so with a PE, it often comes from a deep
and that's
vein
a pulmonary embolus.
Pulmonary embolus. So a clot from the leg often floats to the lungs, but we're seeing a lot of pulmonary embolus anyway with COVID. And so you may not have symptoms in your leg, But if it does float to the lungs, the concerns you would have is you'd feel tachycardic. You'd feel an elevated heart rate at rest, and you'd see a much higher heart rate response with your normal activities. You might feel chest pain. You might feel chest pain with a deep breath, but you typically feel a sudden shortness of breath with that elevated heart rate. And then the other thing that you'd have great concern is if you feel dizzy with this, or if you have syncopal spells where you have a little bit of passing out. Syncope is like a passing out. And so if you have any of that, that's a true emergent sign. And I would be
get to the doctor
911 if I were having those symptoms.
Okay, you hear that? Good advice.
But again, in that early point, I'm talking 2 weeks of COVID, the 4 to 6 weeks after. That's where I'd worry about it more. I wouldn't be worrying it at your stage, Diana. You're exercising a whole lot more. You're doing all that, but I would worry about it earlier on.
Yeah. No, as I often say, I am a good spokesperson. I'm a better spokesperson for this group than I am an example. I've been extraordinarily lucky, and I did feel pretty lousy for several months, but I have been extraordinarily lucky, and I'm, really almost truly, I feel back to myself, other than the glaucoma.
Good.
But I am in the vast minority. So I recognize, I count my blessings. So my next question is for Angela. It's been a while since we spoke. So besides traditional physical therapy, strength training, and managed cardio, would additional therapy techniques be helpful, such as like breathing therapy, meditation, yoga? I'm assuming that's the more gentle type of yoga, because I've been through some yoga classes that were pretty brutal.
Yeah, absolutely. I think, again, people have to listen to their own bodies. You're your own expert. So it's really about what do you need, and are you responding the way that you want to respond? So, again, even that word traditional physical therapy is sometimes hard to navigate, because for us as cardiopulmonary people, it's different than some of your typical sports practices and things like that. Because for us, we think of breathing exercises and chest wall mobility and all these things as, for us, traditional physical therapy. Now, that being said, a good physical therapist, I think, is someone that's going to work with an interprofessional team on this whole this whole pandemic, right? They're going to be learning from referring physicians. They're going to be communicating back and forth. A lot of physical therapists, actually, if they're private practice people, will have dietitians, they'll have psychologists, they'll have massage therapists, they'll have trainers. They might have somebody that's a breathwork coach. Like I know you had Josh Dunce on. They might have them as part of their team that they work with, that they might employ, or that they're going to refer to. And I think if you can get that really multimodal approach, I mean, this virus, I think Talia said it hits every system, whether, every system is highly involved or not, but it hits every system. So it really has to be a full body approach, and it really means we need to do a lot of things. But you're right. I mean, the breath work is great. There's no risk. I mean, we always look at things as a risk to benefit ratio. We're used to working in intensive care units, right, where you can harm someone. So we always put that on a scale, risk to benefit. And breath work is going to be something that doesn't hurt you. It can be very helpful to do the slower deep breathing, to do the nasal breathing, the diaphragmatic breathing. There's no harm in that at all. It's going to help improve your oxygenation. It's going to help with your mind state. It's going to help calm things down. It might help improve your sleep. If you do, especially breathing at night before you go to sleep, it can be part of your meditation practice. Anything that recruits what we call the parasympathetic nervous system that will help calm things down can be helpful. It can even be helpful with pain control. At the same time, as physical therapists, we want to see, do you have the mechanics that you need to do this underlying breathing? If you've been like me, a lot of time working at home on a computer, you might have this kind of slouch posture.
And I sit up.
Right. And so as you slouch, everybody at home, wherever you are right now, if you slouch and try to take a deep breath, it does not feel good. And so by just really expanding your thorax, or that anatomical term for chest, if you expand and take a really deep breath, your lungs didn't change in that second, but your posture changed. So do you have the range of motion? Do you have the postural control? Do you have the pieces? And then especially with a breathing problem, what we see is that you might have good posture when I say, okay, let me see your posture, and you're sitting there. But as I watch you walk across the room, as I see you get winded and then sit down, posture changes. So posture is a very dynamic thing, and it's a big part of our assessment. So I think there's a lot of pieces to that. But yeah, any of the, as long as the yoga is gentle, again, as long as the breath work isn't causing you any increase in symptoms, none of that's going to be harmful. So I think that's an important thing.
So we don't have a ton of time left, and we still have a lot of questions. A couple of the questions I feel like we've sort of covered as we've gone along. So I'm going to skip through so that we can get to as much as possible. If let's just go right ahead to, what can COVID survivors with muscle atrophy start to do to regain their strength, Talia? You're on mute.
I mean, you'd think by now that I would be used to that.
Always said, gotta be.
I think when you're talking in this scenario where folks have sort of a limited energy envelope or a limited sort of bit of endurance, you have to get the most bang for your buck. So in terms of muscle atrophy, what you probably want to focus on initially would be the larger muscle groups. So I'm thinking like the fronts of your legs, the backs of your legs, quads, glutes, hamstrings, all of that power that you need to perform to stand up out of a chair, essentially. Because what that is going to do is that's going to just be really efficient muscle training for you. If you can train those bigger muscle groups, when you start to move, when you stand, when you walk, when you climb stairs, you're going to be more efficient about it. You'll be stronger. Therefore, you're going to expend less energy, and hopefully, you're less short of breath and less winded as you do that activity. So if I were going to start with anything, quite honestly, this is what I start with in the hospital typically, if it's safe to do so, is just the sit to stand and really kick those big muscle groups back on and kind of tell your brain, hey, I'm still here, I still work, and let's sort of gently go into that. So, I mean, it's essentially a squat. Just sit in a chair at home, not a really super cushy, fabulous chair that you really can't get out of, something kind of nice and firm, and see if you can just stand up with ease.
Right.
Do you get dizzy? Do you get winded? Do your legs start to tremble? How many times can you do that before you really feel like you're coming to that point where you're going to get tired, or you can't talk while you do it? You know what I mean? If you don't have enough breath to talk while you're sitting and standing, it's probably a really good time to kind of back off, sit and rest, stand and rest. But I would definitely start with larger muscle groups, and then just any kind of gentle range of motion for your arms, and just against gravity, essentially, up this way, and then get your chest wall involved. I'm just going to do this because here we are, side to side. You're going to rotate a little bit, that sort of thing. Again, it's just reminding your brain that these muscles are present. They work, they're there for you, but they just haven't been used in the way that you've been, in a, I guess, quote, normal way, whatever normal is for you, is sort of kind of kicking them back on, but doing so kind of progressively and gently. Like, I'm not going to go do a HIIT class on my Peloton, in that 4 to 6 week range, because personally, I don't know that I would survive that. But, kind of gentle, low impact over time, again, and resetting your expectations, just because you have a great cardiovascular fitness sort of going into an illness, that's great information to have, but you're going to have to start a little gentler, a little slower. But to get the most bang for your buck, stick with large muscle groups.
So because dysautonomia is such a prevalent piece of the long-term COVID experience, Are there particular exercises? So I know that there's the gamma core that has which is a vagus nerve stimulator that it actually is the only at-home COVID therapeutic with an emergency use authorization, which I find fascinating. But are there exercises and other ways to do that, to sort of help your body start regulating itself properly?
I think there are things, generally, again, I'll go back to in the hospital, that's where a lot of my experience is. Support stockings that will give patients anything to kind of bring a little bit more tone.
I have been,
Oh, yeah.
the best piece of advice that I have been given, and I tell everybody this, when I went to Mount Sinai's Post-COVID Care Center in August, the first time I went, they said, wear ankle to waist compression tights. I have been wearing them every single day. I wear a brand called CWX. It's owned by Walkhole. It's a Japanese running pants brand. I used to run, it's never very good, but I used to be a runner. And it has literally an exoskeleton built into it. And it has done wonders for my recovery. So can you explain why? And so I tell everybody, and again, not the compression socks, from ankle to waist. And these are the tightest, most really, these are really that real compression, more so than Spanx or anything else. I highly, they've done such wonders. Can you explain why?
They work.
Yeah.
I'm going to let Ellen explain why they work, because she's going to do it much more eloquently than I will.
Well, it's a vasotone. So it's your vessel, it's the tone on your vessel. And as I said, it's an endothelial dysfunction, this COVID. And so you lose the tone on your vessels. And so they stay vasodilated. And therefore, when you're in the gravity dependent position, gravity's pulling all your blood where? Down.
Right.
And so your blood is down there, but your heart needs the blood to pump it out. So the way to help get that blood back there is to compress those vessels when they won't constrict on their own. And you're compressing those vessels, and you need a lot of compression. The 10 to 15 milligrams that you get with the TED hose in the hospital is not going to do anything. So the more compression, the more you're sending that blood back. And then with your muscle pumping, with your exercise, you're helping bring that blood back. When you bring it back to the heart, then you have blood coming out and you don't feel so dizzy. If you don't have enough blood coming out of your heart, then you're going to feel very dizzy.
Does the increased circulation also help the repair of the vasculature? Or is
that's not been proven?
That's
so,
not proven.
I don't want to go tell something that there's no evidence.
Right. No,
but there is evidence that the more you exercise and the more you're using those specific extremity muscles, that causes much more of a response to the vessels to respond. So your reactivity of your vessels becomes better the more that you use them.
Got it. Okay, so yeah. Talia, I'm sorry, I totally derailed you the second you got to the
no.
So
no, that's great. No, that's what this is about. This is fluid.
And I want to jump back into that autonomic dysfunction too, because I think one of the issues that I know a lot of the Survivor Corps members are talking about is, that they get dizzy and their heart rate continues to go up. And so the tight compression will help them to decrease some of this dizziness. But there are some people that are developing the syndrome called POTS, the postural orthostatic tachycardic syndrome. It just means that while you're upright, your heart rate goes up and it stays up, and they get very dizzy. Some of them really do need to start a lower level exercise program where they're starting things lying down. They might need to start exercise lying down, and then progressing to what we call recumbent, so sitting activities before they can even do exercise in an upright position. One of the P.A.C.E.R lectures is by Larry Cahalan, but also Johnny Owens. Johnny Owens, you might have seen him on one of the ESPN specials. One of his big research specialty areas, but also clinical areas, is called blood flow restriction training. And so you can look him up under Owen's Recovery Science. They're really starting to look at, for some of these lower level patients, I'm not going to go into all the technical aspects with their time left, but if you can do this kind of modality, you can get a lot of exercise effects to combat hypertrophy with atrophy of the muscles without doing so much exercise. His basis of research is survivors of blast injuries and amputees and military veterans. And so he really has started a lot of this from the ground up and really looked at how can you use really low level exercise and still get a lot of muscle effect. And so there are physical therapists that are certified in blood flow restriction training as well that might help some of these individuals. But the evidence as far as that with POTS, you know, they're just starting to put all these pieces together.
That's very interesting. How about supplements? Are there particular, I mean, I know we spoke briefly about aspirin. Obviously, do not start taking aspirin unless you ask your doctor. It is an anticoagulant, and you have to make sure that there's nothing else that you're taking, that there's no contraindication, even though it is just an over-the-counter product. But are there other supplements that you would recommend that can help repair those vascular issues and the inflammatory issues?
Well, there are some studies on vitamin D, and there's a lot of information coming out about vitamin D. And again, you should ask your doctor before you go and supplement with vitamin D. But vitamin D is actually proving to be a little bit of a hormone, and it really helps with the immune system. I think people mostly look at vitamin D for calcium, but vitamin D has been proven in many studies to really help the immune system. And there's a lot of evidence coming out now that those that had higher vitamin D levels had less severity of COVID. And you can get vitamin D from the sun, but in the wintertime, you're in the north and you're not going to get the vitamin D unless you fly down to Florida.
And I'm not getting on a plane to Florida or to anywhere else, for the record. I will say that since COVID, my vitamin D level was low. I actually got a doctor's prescription for vitamin D. The doctor recommended that, one, insurance paid for it then, and it was a higher strength to take once a week. So my last question is, and I don't know who the best person to take this, maybe Angela is the right one. How about, a lot of people are experiencing nerve pain, numbness, peripheral neuropathy, things like that. Can physical therapy help with nerve pain and numbness, or is it really specifically just for, reconditioning?
No, it can help with that. I mean, it depends on what the source is. I'm going back to Talia, right? It depends. You need that individual assessment and workup. There are patients, especially if they were hospitalized, that will have a pinch kind of an injury where they lost blood flow to their nerves. And that needs a different assessment, and because it has a different prognosis. So, can that nerve regenerate? Yes, but it might take 6 months. That's different than what we call a neuropathy. And this inflammation, so this widespread inflammation that we know is part of COVID, can cause a neuropathy, especially if someone has a predisposing underlying condition like diabetes. They're going to be very prone to that. There are some things that can help with that. Some of the joint mobilization, it depends on where it is. It's often in the feet. Some deep tissue joint mobilizations. There's been a few forms of electrical stimulation that have been found to be helpful in this kind of neuropathic pain.
What kind of stimulation?
It's usually microcurrent that has been helpful for some individuals, but again, it needs that assessment and to find out if it works. So, again, you really need that assessment, but it can be helpful because it affects your ability to wear shoes and to walk and to do a lot of things.
Extremely debilitating. This has been incredible. Thank you all so much. Do you each have a quick final word? I think we only have about a minute left, but does anyone have any, last thoughts to share? I mean, maybe the ultimate question is, can people hope for a recovery? Like, You know, people are feeling
Absolutely.
really, really crummy after many, many months. Is there hope at the end? You know, is there a light at the end of the tunnel for people? Are they eventually going to be able to, you know, look in the mirror and see faces that they recognize? And, you know, if maybe not running marathons anymore, but being able to run, you know, what is the future promising? Tell us.
I think so, and I know it's hard. You know, I'm not in the position of someone who's gone through, you know, all of these things, but I think it's really helpful to kind of switch the narrative a little bit and let's stop talking about what people can't do and what people shouldn't do, and let's flip it and say, okay, what can I do? What can I do now? And then with some intervention and I think it's just time. And unfortunately, we've all had a lot of time on our hands and whatever, you know, so unfortunately, it's going to be a little bit more time, but I think it just goes back to your expectation management for yourself, for those around you. And then just flipping that script and saying, okay, I can't run that ultra marathon right now, but what I can do is maybe go do a 5K.
Right.
That's what I can do. And if we can focus on what we can do, I think we can, you know, kind of get our mindset in a little bit more of a positive light. That works for me personally. I try to do it a lot, but.
And I'm going to follow up with Talia. I'm going to say that this is a neurophysiological kind of phenomenon we're seeing. And I think exercise really does help us feel better. But if we don't do the exercise we think we should do, then maybe we do feel so bad. So again, set your expectations different. And if you're getting exercise in, you will see the benefits. It's just not what you used to see. So we've got to look at what we can do and start smaller. And all three of us have worked with heart failure patients, end-stage COPD, and we've gotten them to exercise and do a lot of things. So people
Absolutely.
who don't have these horrible diseases can do things. And I don't think COVID has taken that all away. I think what happens is we really have different expectations, and there is a neurophysiological component going on.
Absolutely.
And we need to treat both. We need to treat both. So meditation and exercise.
I will add that when I went to Mount Sinai for their post-COVID care clinic, they told me that they should consider the inflammation in my head to be as if I had had an extreme concussion, and to expect for it to take as long as an extreme concussion would take to heal, which has been pretty much on target. So yeah, expectations are a big part of it. Okay, how about you? Any last word?
Yeah, I just want to say again, I'll feed off Talia as far as be kind to yourself, but also advocate for yourself. So if you're finding a clinician, I don't care if they're a physical therapist or a physician, but tell them what you need, right? I think you need to tell them what you need. And you can find with telehealth now, you know, you can find a practitioner that fits your needs. So just continue to search.
Wonderful. Well, thank you all for sharing your expertise. This was really, really interesting and also very, very promising. So there's no news like good news because there just isn't enough of it these days. I'll take one moment right now to remind everybody on the SurvivorCore Facebook page, please go to announcements, fill out every poll under announcements. We ask so little of you. It is so important. And secondly, a reminder, it is National Blood Month. Monday is Martin Luther King Day. It is National Day of Service. I will be donating platelets at the New York Blood Center on Long Island. If you want to come meet me, I'd love to have company there. And please, wherever you are, please come to the SurvivorCore website and sign up to donate plasma if you've had COVID. If you haven't had COVID, donate. You can still donate plasma, whole blood, platelets, whatever you've got, it's needed. There are tremendous shortages going on. It is the best thing that you can do for the world right now, unless you're a frontline worker. So please go sign up for Monday. I'd love to have company. Post your photos and stay safe out there. Thanks so much, everybody.
Thank you,
Thank you.
Diana.
Thank you.